I'm Dr. Ken Landau. Thanks for watching. Let's talk about colchicine. Colchicine was FDA approved in 1961, almost 60 years ago. It's a medicine that's used for two purposes. It's used for either flares of gout, or more recently, it's used for a condition that's relatively uncommon called familial Mediterranean fever. Now, it's not a painkiller, even though it's used for gout. But interestingly, it has a variety of off-label uses. It's used to treat either acute or recurrent pericarditis, or the pericarditis that comes after surgery, after heart surgery. It's used to treat biliary cirrhosis, hepatic cirrhosis, Paget's disease of the bone. It's used for the condition where the platelets decrease in number, the platelets in the bloodstream that leads to ITP, idiopathic thrombocytopenic purpura. It's used for pseudo-gout and idiopathic pulmonary fibrosis for a condition of the skin known as dermatitis herpetiformis. But I'm going to tell you in a little while about the most exciting use and why this drug is probably set for revamp. For gout, well, the dose is take 2 pills right away as soon as you have the first sign of a flare, and then 1 hour later you take 1 extra pill. You don't increase the dose. The total dose, maximum 1.8 milligrams. The pills come in 0.6 milligrams. That's the total dose, 1.8 milligrams. And you can take it irrespective of whether you're taking it for meals, for familial Mediterranean fever, you take a higher dose. Well, the drug comes either as a tablet or a capsule, 0.6 milligram. Other parts of the world comes as intravenous medication. You have to adjust the dose if you have renal disease or liver disease. Now, the American College of Rheumatology says you should begin the treatment of a flare within 12 hours after the onset of an attack, and they now recommend the low dose. That's the 2 pills right away, the 1.2 milligrams, or 2 of the 0.6 milligram pills, followed an hour later by the 0.6 milligrams, total dose 1.8 milligrams. When I was in training, we used a higher dose. We used the 1.2 milligrams right away, but then we used every hour for 6 hours 1 of the pills. So the total dose in the old days was 4.8 milligrams. A lot of people had side effects. The likelihood of improvement, well, more than 50% improvement in around 35 to 40% of the people who have acute attacks of the gout, and that's relatively quickly. But the most interesting part isn't the gout. The most interesting part is what it might do to prevent cardiovascular disease. So the Lodoco study that was presented at the American Heart Association meeting in November of 2013, looking at people who had angiographic proven coronary artery disease. Now, a quarter of the patients had heart attacks previously, a quarter of the people had bypass surgery, more than half of the people had angioplasty. These people were given 1 pill once a day for at least 2 years. Now, the dose that they used was not available in the United States. It was 0.5 milligrams. Here it's 0.6 milligrams. But taking this 1 pill once a day for 2 years decreased the likelihood of an endpoint. And the endpoints were acute coronary syndrome, out of hospital cardiac arrest, and ischemic stroke. So the likelihood of those 3 conditions in people who took the colchicine was 5%. In people who didn't take the colchicine, it was 16%. That's an amazing drop in the likelihood of cardiovascular conditions. This pill might be very important. Now, they did another study. It was called the Colcut study. Low dose colchicine after a heart attack. This was published just in the end of 2019, updated in January of 2020. Looked at people who took the 0.5 milligrams, and it decreased the events by about 35%. Study was based in Montreal. What they did is looked at almost 5,000 people at about 170 different sites. 2,300 people took the colchicine, 2,300 people took the placebo. They also had the standard treatment for heart disease. People were about 60 years old, and in follow-up, which was about 2 years, looking at the likelihood of a non-fatal heart attack, a non-fatal stroke, or cardiovascular mortality, or resuscitated cardiac arrest, or hospitalization for angina that required some sort of intervention. What they found was the likelihood of a primary event, one of those conditions that I just mentioned, In the people taking the colchicine, about 5.5%. Over 7% in the people taking placebo. So the difference altogether was about a 23% reduction. And when you look at the specific subcomponents, the likelihood of cardiovascular death reduced 16%, cardiovascular arrest reduced 17%, heart attack reduced 10%. Likelihood of a stroke reduced almost 75%. Likelihood of urgent hospitalization reduced by 50%. Now, almost all of the patients who were evaluated, who had the benefit, had the artery involved previously stented. Seemed to be less responsive in non-stented arteries. Now they're doing more studies. They're looking at a cold cut type 2 diabetes trial, looking at low-dose colchicine in about 10,000 people. These individuals don't have a history of cardiac disease. They did another study, and they gave people some colchicine right before, about an hour to 2 hours before they had an angioplasty. It didn't seem to reduce the rate of complications. But now there are a series of very large studies looking at this drug. And remember, the drug seems to be very beneficial, and it does not alter the cholesterol, but dramatically reduces the incidence of cardiovascular complications. Sort of the genesis of the whole deal came with the canakinumab study. This was in 2017, published in the New England Journal of Medicine. What they did is they looked at canakinumab, that is a medicine that blocks the formation or neutralizes the IL-1 beta. And IL-1 beta is very important because it sort of puts a person on the pathway toward developing some atherosclerosis and some potential complications of atherosclerosis, heart attack. So what they did is they looked at people who had heart condition, and then they followed them to see if the canakinumab would dramatically reduce the likelihood of another cardiovascular event. And it did. It dropped it by about 15%. And they looked at heart attacks, and they looked at people who had increased C-reactive protein. That's also along the pathway. It's the IL-1 beta, goes to the IL-6, goes to the high sensitivity C-reactive protein. And it seems that it was beneficial. Now, if we go even further back, the original study with colchicine was in 2013. They looked at people who had bare metal stents, and they looked at the restenosis. What they did was they gave the people a dose of 0.5 milligrams twice a day this time, twice a day, for 6 months, and they compared it to placebo. And the in-stent restenosis, so the likelihood of clotting inside the stent, was 16% in the people who had the colchicine and was over 30% in the people who were treated with placebo. So that is a relative risk reduction of over 60%. Well, they did a study called a meta-analysis where they looked at all of the data. Cochrane Group did that in 2016. And they found with colchicine, you could decrease the recurrence rate of myocardial infarction by about 80% and even more in people who had atrial fibrillation and then had an ablation, a cardiac ablation. Well, it reduced the likelihood of recurrent atrial fibrillation within 3 months. 16% in the colchicine group, 34% had the recurrent atrial fibrillation in the standard treatment group. And when they look at the likelihood of stroke, well, they did several studies. They did some randomized control studies. They found a 39% reduction. Now, that wasn't statistically significant, but in a cohort study, they did find a statistically significant, almost 70% reduction in the incidence of stroke. And that was even in the people who were getting the benefit of optimal treatment with their antihypertensive therapy and the anti-blood clotting medicine, the blood thinners, and the lipid reduction. And when they looked at the likelihood of pericarditis, well, the likelihood of pericarditis in people who had an attack of pericarditis seemed to be reduced dramatically by taking colchicine. So the 18-month recurrence rate was only about 10% in people getting the colchicine, and in people not getting the colchicine, it was, again, over 30%. So that's pretty dramatic. So pericarditis is important because it's relatively common and it can be mistaken oftentimes for a heart attack. Causes the typical chest pain, causes the typical radiation. There are some differences that will allow the doctor to make the distinction, but for the most part, relatively close. What are the contraindications to taking the medicine? Well, if you have liver or kidney malfunction, probably shouldn't take it. And if you're taking a medicine that interacts with the drug enzymes, the drug metabolizing enzymes that happen to be in the liver, we call 3A4. If you're taking a 3A4 inhibitor, this drug isn't for you. Or a medicine that interacts with P-glycoprotein, no, you don't take it because that could lead to potentially life-threatening or even fatal consequences. People who are taking those kind of medicines, obviously, if they really need them, they have to be very carefully monitored. And if you have renal impairment, liver impairment, not such a great idea. And you have to be careful of having the medicine out and about. This is not one that you want to overdose or have the child come and take some of the pills. That could lead to a disaster. So keep out of the reach of children. Put it somewhere where you're not going to mistake it for something else. May lead to blood dyscrasias, drop the white count, drop the platelet count, cause aplastic anemia. So you have to monitor people for toxicity if you're going to use the medicine on a regular basis. Neuromuscular toxicity might develop. So people can get some myopathy, cause some toxicity in the muscles, cause the muscles to break down. We call that rhabdomyolysis. Especially if you happen to be taking a statin or a fibrate like gemfibrozil or Tricor possibly. Seems to be worse in people who are elderly, people who have kidney abnormalities. There's a very narrow therapeutic window of the drug, how much you can take before you get toxicity. So with treatment of gout intermittently with that low 1.8 milligram total course, still about 25% of the people get some diarrhea. But in the old days, when I was doing it originally, we were using 4.8 milligrams and 3/4 of the people got diarrhea. Other problems, abdominal cramping, nausea, and vomiting. Some other less common complications caused some problems with the hair falling out, a rash and neuropathy, caused some weakness and muscle pain. It is a drug not to be taken, as I mentioned, with any other kind of a drug that might interact with or inhibit some of those drug metabolizing enzymes. So that would be clarithromycin, would be an AIDS drug, ritonavir, that's now being repurposed perhaps to treat coronavirus. Don't take it with ketoconazole, verapamil, erythromycin, diltiazem. Don't take it with Otezla. Don't even take it with grapefruit juice. Because all of those things might interact with the enzymes. And when you interact with those drug enzymes and you can't get rid of the colchicine from the system, you could have a problem. The overdose, yeah, it can happen. Certainly several hundred people overdose every single year, and about 10% are serious, lead to significant morbidity or mortality. Most of them are accidental. They're not intentional. Typically, the person just takes the wrong dose or mistakes it for some other kind of a pill. The overdose, well, you can have death even as low as 7 milligrams. Remember, the pills come in 0.6 milligrams. So if you take a dozen of them, it could do you in. On the other hand, there are people who've survived who've taken 60 milligrams. So taking an awful lot of the pills. So if you take a relatively small overdose, you might get some burning in your mouth and your throat. You might get some fever and abdominal pain and nausea, vomiting, or maybe a little diarrhea. But if you take too much, maybe a total dose of 36 milligrams or more, you're going to have a more severe reaction. Could have life-threatening complication, multi-organ failure. Your liver can be shot, kidneys shut down, cardiovascular collapse, respiratory depression. So this is not a kind of a pill that you fool around with. If you take even a higher dose, it's 100% fatal. So it's not a pill for pregnant women. It's not a pill for nursing women. Older population, yes, it can be taken, certainly it is very frequently taken, but have to be careful of the kidney function. Make certain that you get a blood test to monitor your kidney function relatively frequently if you're taking the drug on a regular basis. And certainly it's not for people who abuse alcohol. Well, we know that the drug works by several different kinds of mechanisms. It seems to not inhibit the phagocytosis of the uric acid crystals in the joint. So that's typically why you get a gout attack, because the white blood cells gobble up the crystals of uric acid, and then the white blood cells are activated, and then they put out some chemicals, and the chemicals cause the inflammation. That's the gouty attack. Well, it doesn't block the take-up of the uric acid, but what it does is it prevents the white cells from causing the inflammation, from releasing those chemicals that lead to the acute attack of gout. And additionally, we now find that it inhibits something called the inflammasome. And the inflammasome is very important because it's from the inflammasome that we get the IL-1 beta, and then we get the complications of IL-1 beta, and that's activation and degranulation of those white cells and moving around to the white cells. And then on top of that, it leads to production of IL-6, and then that leads to production of the C-reactive protein. So we shut the whole thing down by taking the colchicine. So that's critically important. Well, what do we know about its pharmacology? It seems to reach its peak level in the bloodstream within 1 to 2 hours. And interestingly, it has a second peak in some people somewhere around 3 to 36 hours after you've taken the drug. And that second peak can be somewhere between 40% and 150% of the original peak. And that's due to the recirculation. The recirculation has to do with the bile. There's no routine laboratory test to monitor the serum concentration, but we know the bioavailability of the medicine, about 50%, a little less than 50%, and only about 40% of the medicine is bound. That means a lot of it is out there free to be active. About 50 to 60% is going to be excreted unchanged in the urine. The rest of it's going to undergo this enterohepatic circulation with the bile. Half-life of the medicine, somewhere between about 27 and 30 hours in a healthy person who's young, about 20 years old. If we look at an elderly individual, an older woman who has some impaired kidney function, she only weighs about 100 pounds. Well, when she takes the medicine, her dose is going to be, her concentration in the blood is going to be about twice as great as in the young man. Now, there's relatively small alteration of the chemical in the system. Carcinogenesis not been studied, but it could cause some mutations, some mutagenesis, which means that probably if you're an individual looking to be either the father or the mother of a child, this isn't the pill to take when you're in the process. Well, the medicine itself comes from the autumn crocus, and it was known as early as 1500 BC that it worked on joint swelling. First used for gout in the 1st century AD. Ben Franklin brought the plant back to North America because he suffered from gout. The chemical was first isolated in 1820. It was purified in 1833. And it was used for years and years and years until the FDA decided it needed to regulate a variety of medicines that were on the market but hadn't been studied. So it really hadn't been FDA approved. They'd been around long before the FDA got here. And as a result, those medicines, including colchicine, lacked good treating information and dose recommendations and drug interactions and warnings. So the company known as URL Laboratories from Philadelphia was given a 3-year marketing exclusivity to study the drug. And they invested $100 million, gave the FDA $50 million, and used the rest of it to do some studies. And in the process, the price of the drug went from 9 cents a pill to almost $5 a pill. And that was made even worse when the FDA took all the other brands of colchicine off the market in 2010. And just as an example, the cost to Medicaid went from $1 million a year to $50 million a year just for that one medicine. Well, unfortunately, it's going to be till 2029 when all the patents expire from colchicine. But an interesting side note is that colchicine is used in plant breeding. It causes something called polyploidy, an unusual number of chromosomes. And that leads to new and improved varieties and strains and cultivars of plants. And when you eat your seedless watermelon, it's because of colchicine. Anyway, global sales, they're about $500 million for this old medicine, but it's estimated that by the year 2026, going to be well in excess of $1 billion in sales. Well, how much does the drug cost if you want to go get it? Well, if you want to pay cash for a month's supply, so 30 pills at 0.6 milligrams, the cost is anywhere between $133 cash to $235 cash, but if you have a coupon like you can get at GoodRx for free, it's anywhere between $52 and $148, but if you want the brand name called Colchicine, that's $210 cash or $155 coupon. But if you only are taking it occasionally for gout, not for prevention of heart disease, if you're taking it just for gout, well, 3 pills, cash is going to cost you somewhere between $20 and $40, and with a coupon, $15 to $20. So it doesn't seem to be excessive. So that's the story of colchicine, used for centuries for treating acute attacks of gout, but that sort of indication has been largely supplanted by using the non-steroidal anti-inflammatory drugs, drugs like naproxen. Sometimes we use prednisone. So it certainly has a long track record for treating gout, but the exciting new evidence now shows that it might have an important role in preventing heart attacks and stroke and atrial fibrillation. But remember, the drug carries an awful lot of baggage. So the question is, where is the evidence going to lead? But for now, colchicine, this drug that was approved in 1961, is now a drug of interest. Anyway, thanks for watching. If you enjoyed the show, please tell a friend and consider subscribing so you'll be notified as we post new videos. Appreciate your interest. I'm Dr. Ken Landau.